and all. Welcome to our session on wound management. Today we are having Sister Sandra taking a session for us. So we can start with ma'am's presentation. We can have it for around 40 to 45 minutes, followed by 15 minutes of discussion. By 4 o'clock, we can have our case presentation, followed by its discussion. We can wind up our session by 4:30. Thank you all for joining in. Over to Shiva, ma'am.
Good afternoon to all. So I'm glad to introduce Sister Sandra. She's a staff nurse working as a nursing officer in palliative care unit in Naigames, Shillong, Meghalaya. And she did a certificate course in palliative nursing with Pali in India. So now over to you, Sandra. Welcome.
Ma'am, we can't hear you. Yes, we can hear you now.
So thank you, Sister Shiba, for your introduction, and a very good afternoon to you all. So now we will start it straight away with the discussion. So can you see my slides there?
Yes, we can.
Okay. So now we will be discussing on wound management, and that is of pressure sore and fungating wound. So first of all, let us discuss about pressure sores or decubitus ulcers. So I believe all of you are well versed with bed sore, so it will be like a revision for us. So as we know, pressure points are the prominent bony areas of the body where there is no rich blood supply or nourishment, and also where the skin layer is very thin, which makes the skin become very prone or at risk for pressure ulcer formation. So pressure ulcer is due to localized injury to the skin or the underlying tissue, usually over a bony prominence, such as a result of pressure in combination with shear. When we say shear, it is the deformation of the tissue or the skin caused by two oppositely directed forces, such as what happens when patients sleeping in bed. So the force created between the patient's buttock and the mattress is called as the shear force. Bed sores are also called pressure sores or pressure ulcer. So the pathophysiology, as I hope you can see this diagram, this is the bone, the muscle, the subcutaneous tissues and fat, the skin and the mattress. So when there is a constant weight of the body against the pressure from the mattress for a long time, the muscles, the subcutaneous tissues and fats and the skin, they are compressed, resulting in collapse of blood vessels, in which there is decreased nutrition, oxygen and tissue perfusion, that is blood circulation, leading to tissue ischemia and hypoxia, that is inadequate blood and oxygen supply, and cell death, leading to stress and ultimately causing breakdown of the skin. So these are the common sites of pressure sores when a patient is lying in supine position, in lateral position, prone position, and even in sitting position. So coming to the stages, first of all, let us look into this diagram. This is the skin, the subcutaneous tissues or fats, the muscle, and the bone. In stage 1, the skin may be affected. In stage 2, the skin, the subcutaneous tissues or fats may be affected. In stage 3, the skin, the subcutaneous tissues and fats and the muscles may be affected. Whereas in stage 4, the skin, the subcutaneous tissues and fats, the muscles and the bones may be affected. So in stage 1 pressure ulcer, intact skin, where the skin is red and differently colored spot that do not blanch with pressure. It is hard to diagnose with dark skin. The skin is intact but inflamed. It is painful and warm to touch, and it may be spongy or firm in texture. In stage 2 pressure ulcer, it's partial thickness or blister, where there is a shallow open ulcer into the dermis. It may be broken, red and painful, blistering with possible drainage, without slough, which means that there is no dead tissues, or the tissue may be pale, red, swollen, hardening, and warm. Then stage 3 pressure ulcer, it is full thickness and fat visible. Bone, muscle and tendon may not be exposed, but there may be tunneling. It may not be painful at its base. The skin may be white to black in color, and sloughing may be present. There may be presence of dead tissues, and may have foul smelling drainage and deep ulcer crater present. When we say crater, it means a bowl-shaped cavity. So looking at these images, at these diagram, you can notice it is like a bowl-shaped cavity. So stage 4 pressure ulcer, full thickness, bone, muscle visible. So this pressure ulcer, it extends to the muscle, tendon or the bone. It is white to black in color. It may be painful if the bone is infected. Slough or eschar may be present, and foul smelling drainage is possible. And coming to the deep tissue and unstageable, as you can see in this diagram, in this picture, the surface may not show the whole picture, which means that the depth is unknown. We cannot say how much of the tissues have been involved. So now coming to the causes, undue pressure is one of the cause of pressure sore, as it causes reduced blood supply with the failure of circulation resulting in tissue damage. Friction is also another causes, in which the friction of the skin with a rough or hard surface, it can cause tissue damage. Example, contact with rough surfaces on the bed, or wrinkles of the bedclothes, or even presence of foreign bodies on the bed like breadcrumbs or orange peelings, etc. And even careless handling of the bedpan, in which it may cause friction, thereby resulting in tissue damage. And even pulling the sheets under the patient instead of lifting the sheets, and even use of rough sponge cloths for back care, and prolonged massage without using any form of lubricant. So when the skin contact with moisture is for a long period of time, it can lead to maceration of the skin. So patients who are sweating profusely,
Sister Sandra, we have lost you. Hello, Sister Sandra.
can you all hear me?
Yes, ma'am, we can hear you now, but there is some in between internal connectivity issue. I think
Yeah,
we will be offing your video and you can continue.
yeah, sure.
Ma'am, you need to share the screen
So
again. You can share the screen again and then start your session. Yes.
even causes, I think, done.
From this,
Yes,
from
from
this.
this.
So from this, they didn't get right? Okay. So inactivity is also one of the cause of pressure sore. And then poor nutritional status, that is protein and vitamin deficiencies, diminished circulation or infrequent positional changes, and even acute infection, in which the skin may become larger or more prone for infection. So who is at risk? People with reduced mobility, who is unable to get up from bed or make movements in the bed, they are at risk for pressure ulcers. And then age is also one factor, like the elderly bedridden patients who make very little movements in bed. And low BMI or abuse, like obese, like the very thin and emaciated patients having very little subcutaneous tissues to pad or to cushion the bony prominences, which makes the skin layer very thin and at risk for pressure ulcer formation. weight loss and poor nutrition, incontinence, and having underlying medical problems like neurologic patients with lack of sensation, that they cannot feel any irritation to the skin. So our goals for palliative wound care is to prevent wound from getting larger, prevent new pressure injuries, prevent infection, manage odor and exudate, and assess and treat pain and discomfort. So in prevention, we need to reduce and relieve pressure by using pillows for comfort and supporting the patient, providing wrinkle-free bed, frequent position changing, using air mattress, foam mattress, or water mattress. We should remember that using these type of mattresses, it only delays bed sore. It does not prevent bed sore formation. So even if you are using air mattress or water mattress, you still need to change the position of the patient. Patient beds clothes should be smooth, clean, and dry. So massage, like daily inspection of the skin, oil massage or non-alcohol base, because if you're using an alcohol-based solution, it may cause more dryness to the skin. Apply increased pressure by using hands and use a series of gliding and stroking motions. So we also need to reduce shear and friction by keeping the skin lubricated so that it slides instead of shearing, and limit the use of semi and high fallers position. This is to prevent patients slipping down in bed, which may create that shearing force between the patient's buttock and the mattress. But if it is desired for us to place the patient in semi or high fallers position, what we can do is we can place a pillow underneath the patient's knee so that it will provide support and it will prevent the patient from slipping down in bed. Repositioning, use lifting sheets instead of pulling the sheets, and use skin barriers such as applying emollients to keep the skin moisturized. Maintain clean and dry skin. When I say dry skin, I do not mean paper dry. What I mean is because as we know, if there is excess moisture too, it can cause maceration of the skin. So it must be moisturized. So we can maintain clean skin and dry skin by control of fecal and urinary incontinence, use Foley's catheter or condom catheter, avoid scrubbing, and apply skin emollients to maintain adequate skin moisture and prevent dryness. We also need to encourage fluids and with a nourishing diet that is high in protein and vitamins, additional supplements if needed, and also educate the patient and the family members about the importance of a good nutritious diet as tolerated by the patient. So in prevention of pruritus, it can be prevented by keeping the skin moisturized by topical application, keep the nails short to avoid scratching on the skin. Hot baths and soap should be avoided as it can make the skin more dry. Maintain hydration of the patient and avoid tight fitting and non-absorbing clothes. But instead, we can provide loose cotton clothing to the patient, which will be very comfortable for the patient during the day and evening, even during the night. So the complications of pressure sore, firstly, cellulitis, which is an infection of the skin and the connective soft tissue, resulting in warm, redness, and swelling of the affected area. And then bone and joint infections is when the infection from the pressure ulcer, it penetrates into the joints or the bones. This joint infection, it can damage the cartilage and the tissues, and the bone infection, it can reduce the function of the joints and the limb. And then cancer or marjolin ulcer, when there is a long-term non-healing wound, it can develop into a type of squamous cell carcinoma. And then sepsis, rarely a skin ulcer can lead to sepsis. It is very important to assess pain associated with the wound. So doctors and nurses must assess patient's skin at each visit of the bed-bound and wheelchair patient. We need to chart the findings like measure the width, the length, the depth, the stage, base of wound color, presence of exudate, assess for tunneling, and even describe the edges of the wound. So management depends on prognosis. If the patient has a life expectancy less than 1 month, or his protein intake is low, our goal of care is to prevent pain. Always medicate patient for pain before wound care. We can use normal saline for cleaning the wound or homemade saline, and always use sterilized cloth for wound dressing. We need to keep the wound covered and moist. Use occlusive dressing. When we say occlusive, we mean air and watertight dressing, if possible, to keep the wound moist. We change the dressing only once a day, unless if we are using occlusive dressing, then every 5 to 7 days. If there is an odor, what we can do is we can crush this tablet metronidazole into powder form and mix it with a lubricant, either paraffin or Vaseline, and we spread it on the wound. We can also nebulize injectable metronidazole, and keeping charcoal in a bucket, maybe under the bed or in the patient's room, it helps to absorb the odors. And if slough is present, dead tissues are present, we can debride it surgically. And if exudate is profuse, we clean out with a syringe filled with homemade normal saline and dress it with the absorbent dressing. So for homemade dressing supplies, what we can teach the caregivers is to take 200 ml of boiled water, add a pinch of salt, or 1 gram to 1 liter of boiled water. And since wounds are not sterile, the saline has to be clean and not sterile. And we also need to keep the economic factor, the economic background of the patient in mind. As some patients, it is very difficult for them to buy gauze pieces every now and then. And since they will need that the dressing should be done every day. So what we can do is we can ask them to take old cotton saris or dhotis, cut them into squares and steam them for half to 1 hour. And we can impregnate them with Vaseline or liquid paraffin. By doing this, it becomes like an occlusive dressing, or it also prevents the dressing to adhere on the patient's wound, which may be very painful on removal, or even it can cause bleeding if the gauze piece or the dressing material it gets stuck to the patient's wound. So when caring for patients at end of life, it is important to remember that during the time of active dying, the patient's wishes for pain control and comfort, it may outweigh the desire for pressure sore prevention. And providing comfort measures like respecting the patient's choices in turning schedules and include whether they have a position of comfort. And hydration goals should be compatible with the wishes and patient's condition. And wound care for existing pressure sores should focus on reduction of pain, minimizing odor, managing exudates, and other symptoms that may impact the quality of life. Family and caregivers, they should be made aware of the goals and plan of care, and our focus should be on the promotion of quality of life improvements such as comfort and management of wound symptoms as identified by the patient. So I hope you are all clear with bed sore. So maybe the discussion will be later. So I'll just carry on with fungating wound. So this fungating wound, it is a primary or secondary malignant growth in the skin which has ulcerated and is difficult to heal. And these fungating lesions are fast growing and typically resemble a cauliflower or fungus-shaped structure extending beyond the skin surface. So this is the image of a patient who has a malignant fungating wound. So the pathophysiology of a malignant fungating wound is when the cancerous cells, it invade the epithelium, it causes infiltration to the supporting blood and lymph vessels, resulting in loss of vascularity, loss of circulation and nourishment to the skin, resulting in tissue death and necrosis, and then malignant fungating wound. So the problems of a patient with a malignant fungating wound is physical, psychological, social, and spiritual. So coming to the physical problems, firstly, let us discuss about pain. So as we all know, pain is an extremely burdensome symptoms, and patients and caregivers have reported wound pain as one of the worst aspects of having a wound, because it disturbs sleep, mobility, mood, relationships, and all factors that reduces the quality of life. And wound pain during dressing changes and cleaning is reported to be the time of greatest pain. Malodor: garbage, rotting flesh, or rotting meat, and cadavers were the words described by the patient and the family members when they were asked to describe about the malodor from the malignant fungating wound. And this malodor, it causes gagging, vomiting, weight loss, social isolation, withdrawal among the individuals, leading to poor quality of life.
Sandra,
Sister Sandra?
Of the skin and maceration.
Ma'am, we
Yes.
lost you in between. So can you start from
Oh,
malorder again?
okay. So, coming to malodor, garbage, rotting flesh, or rotting meat, and cadavers were the words described by the patient and the family members when they were asked to describe about the malodor from the malignant fungating wound. And this malodor, it causes gagging, it causes vomiting, weight loss, social isolation, or withdrawal among individuals and their caregivers, leading to poor quality of life. And then exudate is an excess of leaking fluid from the injured tissue. So having a heavily exudating wound, it may cause an overhydration of the skin and maceration, leading to further skin breakdown, infection, pain, or pruritus. And bleeding is due to fragile tumor capillaries in the wound bed and platelet being absent and their functions being suppressed. Pruritus or itching is due to stretching of the skin, which may be irritating to the nerve endings. And then infection, where cancer and its treatment may increase the risk of infection development. Nausea and anorexia may be due to the malodor from the wound, fungating wound, or even infestation with maggots. So now coming to the psychological problems. So firstly, altered body image and disfigurement. So as we all know, body image has a great impact on the psychological well-being because it is associated with one's identity. And having a disfiguring lesions are a constant reminder of leading to feeling of hopelessness. And the presence of a malignant fungating wound at times was found to cause more psychological suffering than the cancer diagnosis itself. Anger. Like patient may be angry that he was diagnosed with this terminal illness, or he may throw his anger at his family members, at his wife, at his children. And then depression, like a patient may feel a loss of self, meaning he may feel that he is no longer the person he or she used to be. Embarrassment, shame, maybe a patient may be embarrassed due to the growth of the tumor or due to the foul smell, and maybe feeling of helplessness. Anxiety, like a patient may be very anxious at the thought of what the tumor was doing inside her body when she could see what the malignant fungating wound was doing on the outside. And even fear of pain and death. Maybe a patient had a past experience of any one of his family members or maybe close relative or friends who was diagnosed with same type of cancer, and seeing that particular relative screaming, shouting because of the pain and dying in pain, he may also have that fear that he will also have to undergo through the same pain, horrible pain, where he will be screaming in pain, whereas his family members will just watch him, surround his bed and watch him screaming and dying in pain. So that may be one of the fear. And maybe fear of death. Like one patient stated, I don't want to die, but this wound looks as if death is more and more near me and I can't escape it. So I hope you are clear with psychological problems. So coming to the social problems, family isolation. Like there are some patients who avoid talking about the wound with their family members, or even they never show their wound to the family members. And there are also some family members who does not even know that the wound existed. Raja Lakshmi, is it okay?
Yes, ma'am.
Oh, okay. Just give me a sign in case if the video is not, if it freezes.
Okay, sure,
Thank
ma'am.
you. So when I talk about family isolation, I remember there was a patient
Sister Sandra, we have lost you.
who was diagnosed related this to the
Hello, ma'am. Sister, we have lost you. Sister, we have lost you in between.
Can you hear me?
Yes, ma'am. You can
Okay,
continue,
so
ma'am. We stopped with family isolation. You're
okay,
talking about
thank
the
you.
presentation.
I'm
Yes.
so sorry because I don't know what's wrong today. There's no internet connection here.
No worries,
So
ma'am. You can continue.
So I have an example of family isolation where there was a patient who was diagnosed with right breast cancer, and when we went and sat with her, asked for a history collection, what she did, what the husband told was he only came to know about his wife having cancer, having a wound, only when he came back for a holiday as he is in the army. He said that the wife came to the station, she was wearing a sari and wrapping a shawl around her on a hot summer day. And so maybe he thought that maybe because she came out, that's why she wrapped a shawl around her. So when they reached home, the wife was still wrapping that shawl. So he told her like, why are you wrapping this shawl? Because it's such a hot summer. So the wife said that I'm having common cold, so I don't feel like taking my shawl off. So after that, the husband said that he will go and visit his friends. So in the evening, while the wife was preparing dinner, thinking that the husband is still outside, is still
Sandra?
Construction sharing one man came. The class
I'm done with family isolation, right?
Yes,
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 yes.
yes.
Okay. I can't share my screen. Okay. Can you
We
see
can
my
see.
screen?
Yes, yes, we can see.
You were sharing this patient story.
Rejection by relatives, where one patient has described herself as feeling apart, falling apart, and feeling marginalized from the society. That is, she feels like she is unimportant in the society. She feels safe only in her own surroundings and away from the eyes of others. Then social stigma, fear of contagion. Like one patient has previously told us that he previously traveled with his best friend. So now after being diagnosed with cancer and after he has this malignant fungating wound, his friend no longer traveled with him due to the fear that he may contract the disease. So friends and relatives, they are reluctant to go near the patients or even eat from the same utensils due to fear that they may contract the disease. There was a patient where, when we went to visit the patient, we could notice that there was a mark on her plate, her spoon, and her glass. And when we asked the patient what was that mark about, she suddenly broke down into tears and told us that that was marked by her mother, her father, her sisters, and brothers. They They have put that mark so that they will know that that plates are only for her to be used, due to the fear that the curse may also come upon them, or they may also contract the disease. But then she is blessed to have such a supportive husband who, during our conversation, he didn't utter a word, but what he did was he took her glass and started pouring water on that, and he drank from that glass. Even in spite of the wife, she was crying when she saw what her husband was doing. When she saw his gesture, she gave a slight smile and was happy that at least the husband is supporting her. But imagine, what is she going through right now because of what the family members are doing. And then loss of job or income, like earlier the patient was the breadwinner in the family, but now he can no longer support financially. Then loss of social position or loss of position in the family, like earlier the patient, if he was the decision maker in the house, now after being diagnosed with this illness, he is confined to his bed and he cannot make decisions like what to eat, what not to eat are being made by his other family members. Effects on family, like it can be financially, it can be due to embarrassment due to stigma or distress, or they may feel helpless as they are unable to comfort their loved one. It can be depression, etc. And effects on sexual relationship and marital disharmony, as there is a constant reminder to both the patient and the patient's spouses that they are living with a rapidly progressing terminal illness. And there may also be significant loss of intimacy due to fear that one may cause more pain or discomfort. So, coming to spiritual or religious problems, there may be interference with religious rites. Like there is some religious belief who believe that they should not take any form of medicine for any illness, but instead they should just pray. So imagine a patient with a malignant fungating wound having an excruciating pain but is unable to get the pain medications, as it may interfere his religious rites, religious belief. And then a patient may question like, why me? I've never smoked, never touched alcohol. I've always led a good life, helped the poor and the needy. But then why me? Why am I getting this wound? Why am I getting this illness? Then why did God do this to me? Like maybe I am being punished for my past sins, thinking that this is his karma. So our principles of management is palliation of symptoms, holistic care, and empowering the patient and family in wound care. So in wound assessment, we need to assess the type of wound, whether it is adherent or non-adherent, black, necrotic, green, and yellow slough, the amount of exudate produced, the depth, whether it is superficial or deep, presence or absence of odor. We have to assess if there's any history of bleeding or description and the intensity of pain. And also if there is any signs of fistula or sinus formation, condition of the surrounding skin, like if it is red, macerated, fragile, or the skin is showing any signs of infection. Also assess the site, location, surface area, and presence of nodules. Physical, psychological, social, and spiritual problems due to wound should be paid attention. Then our criteria for wound dressing is empathic and loving care. Provide a thorough bath before dressing. Use normal saline for cleaning the wound. Use absorbable dressing to remove exudates, and paying attention to wound margin and healthy tissues. So the proper approach to the management of malignant fungating wound shifts from healing to addressing quality of life. So in wound cleaning, unless otherwise indicated, the fluid of choice for cleaning is by boiled and cool water. And if so desired, we can add a pinch of common salt, or we can also use normal saline if affordable. Then cleaning is best achieved by showering the wound instead of swabbing, as swabbing can be painful and traumatic, hence it is to be avoided. The water used for cleansing should be warm to at least room temperature. And remove the necrotic tissues by gentle debridement to flush away the dead tissues. Then chemical or surgical debridement of these wounds is not recommended. We need to maintain a moist environment to to prevent trauma, which may result from wound drying or fissuring. And when we maintain a moist environment, it helps to stimulate the epithelial cell migration over any normal tissue to facilitate resurfacing. And then apply a layer of non-adhesive gauze and secure with bandage or adhesive tape. So in management of pain, as we know, the skin has the most sensory nerve endings of any organ in the body, and pain can be experienced in different ways and is unique to each individual. And pain is what the patient says hurt. If he or she says it does, we have to believe the patient regarding his or her pain. So the assessment and management of pain due to fungating wound is a vital aspect of the patient's holistic care. We need to assess whether it is nociceptive, neuropathic, or mixed pain. Pain during dressing changes can be managed by local and systemic agents, and local anesthetic agents like lignocaine 1% and bupivacaine 0.25%. It can be applied over a piece of gauze and covering the wound for about 15 minutes prior to dressing to reduce the pain. And the systemic agents is to be given 30 minutes prior to wound dressing. And malodor, it is caused by necrotic dead tissues or heavy colonization of bacteria or infection, which is attributed to the presence of anaerobic bacteria. When we say anaerobic bacteria, it is the bacteria who can grow without the presence of oxygen. So when there is bacterial metabolism, it causes release of volatile fatty acids, which is a source of odorous discharge. And the malodor from a fungating wound can make a patient feel like he or she is rotting away. This malodor, it can permeate into the surrounding environment, making tasks such as meal times and receiving visitors unachievable for some patients. So daily cleansing and dressing is needed. Oral metronidazole, we can crush the tablet into powdered form and apply it on the wound. Topical metronidazole if available. If it is a dry or painful wound, we apply metronidazole powder and we mix it with xylocaine jelly and spread it on the wound. Then we can also irrigate it with injection metrogel, systemic antibiotics, frequent changing of dressing, and using charcoal dressing, foam dressings with silver and papaya. The activated charcoal layer in the charcoal dressing, it neutralizes the offensive odor from the fungating or the infected wound. And in foam dressings with silver, the antimicrobial property, it helped to reduce the malodor and infection. And even papaya dressing is known to have a desloughing and wound healing properties. So modifying the environment like increasing airflow by opening windows and fan, cat litter. So far we have not tried this, but it has many in the literature. I found that cat litter is known to reduce odor, but so far we have not tried. Coffee ground, it really helps to reduce odor. Keeping a bucket of charcoal under the patient's bed or in the corner of the patient's room, it does help to reduce odor. And air freshener, but avoid spraying in front of client. But most of our patients, they really do not prefer us using air freshener, as they said that they do not like the smell. So depending on what the patient is comfortable with, we do that. So coming to exudates, the fungating wound often produce moderate or large quantities of exudates as a result of increased permeability of vessels within the tumor and because of the action of the bacterial enzymes. So unless exudate is controlled, related problems like soiling, peri-wound maceration, leakage, and odor will not be effectively managed. So dressings should be selected that can best conceal the wound, absorb exudate, and reduce odor. Dressings are generally changed 1 to 2 times a day based on the amount of exudate and odor. And major categories of dressings include foam dressings, alginate, and hydrofibers based on diaper technology. So even menstrual pads can be especially effective because of their good absorption and availability, and can be like we can get it at a very much cheaper rate. But we need to discuss it with the patient prior to ensure acceptability of the patient. So in management of infection, we can give topical or systemic metronidazole, daily dressing with metrogyl, and systemic antibiotics. And in management of pruritus, cool compress, shower or bath, cool creams by keeping it in fridge, and then it also helps to soothe the skin. Oral hydration, applying lotions frequently, providing a humidified environment, fingernails to be short and smooth, good hygiene, alternative skin stimulation. Example, instead of scratching, we can ask the patient to gently pat the skin or give a slight massage. Avoid tight, irritating clothing. So in management of bleeding, bleeding occurs mainly during cleaning, dressing removal, and any other traumas. So dressing should be soaked with normal saline or homemade saline before its removal. Apply local pressure, but this local pressure should be applied carefully as the tissues are fragile. Sucralfate powder will also help to reduce the bleeding. Giving oral or parenteral ethamsylate, it increases platelet adhesion and it may help to control bleeding. Then adrenaline packs, which may help to control bleeding by causing local vasoconstriction. But it also carries the risk of systemic absorption, which may result in increase in blood pressure and rebound bleeding. So if patient is very severe, if bleeding is very severe, and if patient has a very advanced disease, interventions to stop bleeding may not be useful. So in such cases, the non-pharmacological management, such as use of green or red towels during bleeding, example, such as erosion into the carotid artery, it can cause major hemorrhage and ultimately death. So for patients where erosion into the major artery is a potential complication, families should be prepared for this potentially catastrophic event, such as by using of green, red, or dark colored towels during severe bleeding to make such an event as manageable and minimally distressing as possible, so as to decrease the anxiety and fear of the patient and family. These dark towels are used to camouflage or to hide the blood loss or the appearance of the bright red blood, which may be very terrifying to the patient and the family members. So as we all know, prevention is better than cure. It is important for us to teach the patient and the caregivers about the importance of covering the wound to prevent breeding of houseflies, which may lay thousands of eggs resulting in maggots. And if there are maggots, a piece of gauze can be soaked in turpentine. And this gauze can be held close to the wound of the patient, which will bring the maggots out so that they can easily be removed. And then physical removal of maggots. So impact on the patient and the family. We need to address the physical, psychological, social, and spiritual concern. Pay attention to outward appearance of the individual. It is important to educate the patient and the family, like on the signs and symptoms of infection, pain management details, dressing changes, report wound conditions like bleeding, exudates, malodor, and pruritus, so that prompt management can be taken. And optimizing patient and family autonomy by enhancing mobility, activity, maximizing nutrition, providing home care services as required, involve patient and family in care decisions, having an open and honest communication of goals and decisions, and access to support services that will improve the patient's quality of life, and assess and consider the financial situation of the family. So address the psychological issues and coping strategies, like recognizing that non-verbal caregiver reactions to the wound will be observed and interpreted by the patient. We also need to encourage discussion by patient and family of their concerns and feeling, because most of the time patient and the family members, they create this wall. We can also call it as the wall of love, where they do not want to discuss about the wound, about the terminal illness, fearing that that may cause more harm to the patient, and even the patient avoiding the topic, avoiding the discussion due to fear that he might be a burden to his family members. So we need to encourage open and honest communication. Be open to cultural or alternative patient and family approaches. Consider benefit of diversional therapies such as music, massage, relaxation, or meditation. And consider referrals as needed, like referrals to the medical social worker, referrals to the dietitian, to the physiotherapist, or any as such. So in conclusion, you treat a disease, you win or you lose. But when you treat a person, I guarantee you'll win no matter what the outcome. So I hope it is clear now. So I'm really sorry for the technical error.
Okay, thank you, Sandra. So the time for
Thank you so much. I'm
clarification.
really sorry.
No problem. So there is this is the time for clarification of their doubts. So if they
Okay.
have any doubts, they can clarify with you. So Dilasa team and Mahatma Gandhi team.
I can't hear.
So we have a guest with us. So Dr. Sunida, Dr. Punya, sorry, Dr. Punida. So she wants to share something.
Hi, thank you so much for the wonderful presentation. It was really, really nice. Just wanted to add something that, I have seen something what is called as a Kennedy ulcer also in my experience as a palliative care doctor. And this is an ulcer which is seen usually towards the end of life, very close to to the dying process. This is an ulcer which is rapidly progressive, and instead of growing horizontally, it grows vertically. And as Sister Sandra mentioned before, the goal at that time really becomes optimizing the quality of life for the patient and making sure the other psychosocial issues are taken care of and the pain is taken care of, instead of the focus being on the management of the patient. So usually, these kind of ulcers can be seen maybe a few weeks before death to few days before death. But the key is that this is very, very rapidly progressing, like from a blister, this ulcer can go on to like a full-blown ulcer which has gone vertically. That's known as a Kennedy ulcer. So just wanted to add that piece.
It's a new information. Thank you, ma'am. Okay, Dilasa team. Any doubt?
I have no doubts.
No.
Mahatma
Ma'am, can I know what is social stigma fear of contact in social problems? It was written. Slide.
Sandra?
Social.
Yes.
In social problems, it was written that social stigma fear of contact. Can you explain, Miss?
Yeah, like what I told you was there was a patient who said that he always previously traveled with his best friend. But after he was diagnosed with cancer and after he had that malignant fungating wound, the best friend, he no longer traveled with him due to fear that he may contract the disease. And sometimes there is a stigma that you may contract the disease, or maybe it is a curse. Having cancer is that a curse has come upon you because of your karma or past sins. So friends and relatives, they may be reluctant to go near the patient or even eat from the same utensils due to fear that maybe they may contract the disease, or maybe that the curse may come upon them. As I think, if you can still recollect, I've given you example of the patient whose plate, spoon, and glass was marked, like there was a red color mark on that utensil, so that they will know that that is to be used only by the patient, due to the fear that that curse may also come upon them. So are you clear with that?
Yes. Mahatma Gandhi team.
Yes, ma'am.
Thank you, ma'am. So, any more clarification required?
No, ma'am.
Okay, so I think we can move on to case presentation. I suppose Sister Gautami is not there.
Ma'am, this is Gautami, ma'am.
Okay, sure. So I think the case presentation is from your end, so if it would be good if you could stay mute.
Unmute. Okay. Can I start, ma'am?
Yes, you can start.
Good afternoon, everyone. This is Gautami, Mahatma Gandhi Cancer Hospital. Today, my case presentation. My patient name is M. Jagannathan. M. Jagannathan, 71 years old male patient, diagnosed with hepatocellular carcinoma for evaluation. Presenting complaints: abdominal distension, yellowish discoloration of the skin, loss of appetite, drowsiness, abdominal pain, constipation, weakness, and pressure sores. History of illness: past history of amputated leg in 2018 due to small wound developed in left foot and to form gangrene after doctor advised amputated her leg. So, history of abdominal pain, decreased intake of food in November 2019. Consulted Lalita Nursing Home in Srikakulam. Routine investigations done. Ultrasound abdomen taken. Referred to MGCH. Again ultrasound abdomen taken. Examination: he was conscious and oriented, unable to sit due to abdominal pain and discomfort. Pain score 2/10. Pain site at abdomen radiating to lower back. His discomfort in sitting and standing position and patient unable to walk due to amputated the leg. Bowel and bladder pattern is abnormal. Decreased oral intake. He was diabetic and hypertensive. Pressure was present. Patient not cooperative to take treatment. Routine blood test done, ultrasound abdomen, PET CT, reports to be collected. Treatment is admitted on 27th November 2019 for symptomatic treatment. Psychosocial aspects: he was married, patient retired teacher, wife is the primary caregiver, she is housewife. They have 2 daughters, both are very supportive. Entire family was very supportive. Patient is not cooperative to take treatment and patient in depression because amputated leg. Medications: injection Joy 1.5 grams twice a day, injection Pantap 40 mg twice a day, injection Dita 10 mg twice a day, injection Optinurin 2 ampoules in 100 ml NS once a day, injection Otski 1 ampoule in 100 ml NS once a day, tablet Udiliz 300 mg thrice a day, syrup Crimafin 15 ml at bedtime, ointment Hydrohil. Patient concern are: patient feels he went to go home to take food and comfort. Family concern are: patient cooperated to take treatment, comforted to take food. A 71 years old male patient admitted with abdominal pain and discomfort, decreased oral intake, decreased urine output, and yellowish discoloration of the skin and abdominal distension. Routine investigations done, PET CT done, reports to be collected. Now patient unable to walk due to amputated leg and weakness also. Patient diabetic and hypertensive, pressure was present. Now he getting symptomatic treatment. Patient is not cooperative to take treatment and feels he want to go home. Discussion points are: what more we can do for this patient? What are the nursing management for pressure? How to counseling to the patient to take treatment?
Thank you, Gautami, for the presentation. So, anybody would like to ask any clarification regarding this patient story? Dilasa team.
Any clarification regarding this patient story?
Oh, ma'am.
No. From your patient story, I understand that there is a pressure sore, but where is the site of pressure sore?
Scapula side, ma'am.
Scapula.
Yes, ma'am.
Sandra?
Yes. Can you hear me?
Yeah, anything you want to ask them?
Yeah, so actually her concern was, can you please go to that slide, patient concern and family concern?
Previous slide. So we will share.
This one, ma'am.
Where?
Yeah. So here, yeah, that is the slide. So they said that patient's main concern was that he said that, yeah, that patient concern and
Patient
yeah,
feels he
family
went to
concern.
go home, ma'am.
So patient feels like he want to go home. So like, have you asked the patient what is the reason? Like, why does he want to go home?
Ma'am?
Because you said that the patient says that he wants to go home, right?
Yes, ma'am. Yes, ma'am.
Have you tried asking the patient what is the reason behind that?
Is discomfort in hospital surroundings, ma'am.
Pardon? Maybe see firstly na, when we say that patient wants to go home, so is it because of the financial problems that he fears that as you have mentioned, he is a retired teacher and also his wife is only the, like, she's the housewife, or maybe he has the fear that he may a burden to the family, or fear of the increased cost in the hospital, or I just want to know like where his symptoms and pain and under control, or is it still the same like prior to his admission, or
But
maybe a patient he may also feel, pardon,
because of the burden, ma'am. And patient psychologically,
because of the being a burden on his family members,
yes, ma'am. And
is that the
patient
reason?
psychologically depressive and discomfort in hospital surroundings. He feels
Maybe
discomfort.
that might be one, because he may feel uncomfortable being in an unknown and isolated environment, instead of being like surrounded by his caregivers, family members, or he may also feel safe in his own house.
Yes, ma'am.
So uh, and regarding the family concern, like you said that they want the patient to be cooperative to take treatment. So what type of treatment are you talking about? Is it chemotherapy, radiation therapy, or is it
Only
symptomatic
symptomatic,
management?
only symptomatic treatment.
Okay, so is there any procedure that he is undergoing which has to be done only in the hospital?
Varnam, can you repeat,
If
ma'am?
not so, then I think his symptoms can be treated at home too. Like, I'm asking if is there any procedure which the patient has to undergo every day which can be done only in the hospital? Because if that's not the case, then I think patient can also, like, his symptoms can be also treated at home. So I
Yes, ma'am.
think if the patient is sent home, allowing him to be in the comfort of his home while his symptoms and is also being managed at home. And I think if dressing of bed sore is your main concern, you can teach the caregiver, you can empower the wife to do the wound dressing. So
Yes,
I don't know, that is just my suggestion, but then if Sister Shiba can, and any other can give some more opinions on that.
Yeah, I need to know that what is the goal of admission for this patient? So
cause of admission, abdominal distension, and decreased urine output and decreased oral intake, ma'am.
so now how is she? So how is he now?
He's fine, ma'am.
He's better now, or
Patient discharged with stable condition.
okay? So then why he is staying in the hospital right now? he is stable now. Why he is staying? Why he is admitted in the hospital right now?
For evaluation, ma'am, hepatocellular carcinoma for evaluation. That's why he stayed in the hospital and for and symptomatic management and investigations reports to be collected.
Okay, now is the curative management is going on or symptomatic management is going on?
Symptomatic management.
Okay.
Is there any plan for curative treatment? Like, what is the plan from the doctor's perspective, first of all? And secondly, what is the understanding of the patient and the family of what he has? Has there been a discussion of that? What can be offered from the medical provider side? And, what is the understanding that the patient and family have? And then having a conversation about what their goals are.
Did you talk to them?
Yes, ma'am.
Okay. What is their concern about that family members concern about his patient? His patient.
To take treatment, ma'am, and comfort and decrease the symptoms, and to take food, ma'am.
So what did we do for his abdominal pain? Sorry, I may not be knowing some of the, brand names, the names that are here, so I may not be knowing that. Generic names I would understand. Pantop is pantoprazole.
No. What is injection SOAT?
Joac, antibiotic, ma'am. Joac is antibiotic.
What is diator?
That is fluid.
Which one?
Crucimide, ma'am.
Crucimide.
Okay.
Okay. There is no analgesics in these medications. I think. What is optineron?
Optin is multivitamin.
Multivitamin. So the patient is having the pain score is 2/10, right?
Yes, ma'am.
Okay. So any pain medication there?
No, ma'am. Only Pantop is good.
Pantoprazole. What was the abdominal pain attributed to? What was the cause of the abdominal pain? Is it ascites or is it constipation? Is it bowel obstruction?
Constipation.
Constipation. Okay. Is there any laxative? I may not know the generic.
Yes,
Gromafin.
is there.
Did he lubricant?
Yes.
Okay. The other concern that I have is this patient has hepatocellular carcinoma. So these patients are prone to hepatic encephalopathy as well. So do we think that this patient is making decisions based on a clear understanding of the disease condition that he has, or is there a component of hepatic encephalopathy impacting his choices?
Did he knows the diagnosis?
Yes, ma'am.
What about family?
Yes, ma'am.
Usually in hepatocellular carcinoma, because there is concern about hepatic encephalopathy, in those situations, instead of cromefin, which is a stool softener, we've used lactulose. Because one, it's a laxative, and secondly, reduces your ammonia levels also, and impacts the encephalopathy also. So with the target being 2 to 3 bowel movements per day.
Anything you want to add?
No, ma'am.
Sandra ma'am, can you unmute and speak? Yes, ma'am.
Yes, pardon?
Anything you want to add?
Yeah, I think most of the points has been discussed because madam has already mentioned about the importance of also treating the patient's pain. Maybe because if the patient is not feeling comfortable, he feels like his condition is still the same thing prior to admission. That may be the reason of patient wanting to go back home. So do you hear me? Can you hear me? Am I audible?
Yes.
Yeah. So maybe even for his other symptoms too, if it has not been managed properly, so maybe that may be one of the factor. And even in patients and family concerned, I feel like both the family and the patient, they want the patient to feel comfortable. And okay, they said that they want the patient to be cooperative to take treatment. Maybe the doctors need to explain about the management plan, the treatment plan. And but both patient and family want him to like to be able to take food and to be comfortable. And I have not seen a line where they say that they want the patient to get cured. So I think our main concern should be on that, like providing comfort to the patient, improving his quality of life, respecting patient's choices. If he says he wants to go home, and if we can do that, then I think he will be much happier at home. And looking even at his age, he's already a 71-year-old man. So if there's anything you need to add, so yeah, I think I'm done from my part.
Okay. The other thing would have been like, an easy management of his pain, if that was because of ascites, would have been, would have been a tap, an ascitic tap that would have decreased the distension and resolution and relief from pain.
Yeah.
And I think you can talk to the patient directly why he is reluctant to take treatment. I think you can go and sit with him and talk to him why he is reluctant to this treatment. So if there is any maybe some problem behind that, anyway you can go there and talk to them, talk to him. So any problem. Maybe is the physical, as Sandra told, his physical problems day by day increase. No relief, his physical problems in the hospital. That is why he might be so wants to go to home. So you have to talk to him and find out the problem behind that. And the second discussion points, what are the nursing management for pressure sores? So we already discussed. So anything you want, any doubts regarding the nursing management of pressure ulcer? First thing, we need to understand that the causes of there are three main causes of pressure ulcer. One is pressure, second is friction, the third one is moisture. So the changing of position every 2 to 3 hours is essential. So we need to inform the patient and the caregivers the importance of changing position. So we have to talk to them regarding the changing of position. And while we change the sheets, we already discussed, instead of that pulling the sheets, we have to turn the patient on side, and we pull the sheets under the patient, and then we have to turn again this opposite side, then we have to remove the sheets. That's why we prevent the friction. And moisture. So if there is any moisture there, we need to change the sheets that as soon as possible. And another thing is nutrition. So if we change the position 2 to 3 hours early or whatever it is, even then the patients develop pressure sore maybe because of poor nutrition. So protein intake is the major thing. So make them take. You can make sure that whether they have take adequate nutrition protein intake in their diets. So this is the important points for prevention of pressure ulcer. And the another thing is apply moisturizing agent when the daily skin inspection is essential. So while we change the position, we have to see the patient's skin. If there is any red color, maybe the skin stage 1 red color is there. So the management of stage 1 is to prevent further pressure on that area. So if there is a red color skin is there, you can prevent further pressure on that area. So the second stage management, only this dermis layer is breakdown, only red color is there. So you can clean with normal saline. That is enough for the second stage. The third stage, maybe you can use antibiotic cream or metronidazole tablet. You can just wash with no hypochlorite solution like povidone iodine solution or hydrogen peroxide in this patient. If you use hypochlorite solution like povidone iodine solution and hydrogen peroxide, that will destroy the granulation tissue. So you can use normal saline for cleaning. So the second thing is fungating ulcer. Regarding the fungating ulcer, how will you manage exudate? Dilasa team and Mahatma Gandhi team. How will you manage exudate?
Frequent dressing, ma'am.
How often you change the dressing?
Daily, once or twice.
Too much exudate, then twice a day.
Twice a day. If the exudate is heavy?
Charcoal dressing.
Charcoal for what? Charcoal for what? Order. Talking so okay, charcoal is the good agent for absorbing bad smell. I'm talking about exudate. The exudate oozing out of fluid from the wound. So how will you manage in fungating wound patient? There is a chance of high exudates in case of fungating ulcer. So you can use Gamgee pad. Usually we apply Gamgee pad, one or two pieces of Gamgee pad over the wound. So instead of 1 or 2 pads, you can use the 3 or 4 numbers of pad together and apply. So that exudate, if the more exudates will come out, that Gamgee pad will absorb. If you change the dressing frequently, that again increase the anxiety. Why it happened to me? Something like that. So instead of that, you can use more Gamgee pad. So that you can reduce the timing, the dressing change timings also. So maybe you can, instead of using 1 or 2 pads, you can use 4 or 5 pads at a time. Anything you, Sandra?
Hello.
Yeah.
Shiva, yeah, I believe everything has been covered.
Yes.
And you have also mentioned all the important points. So thank you so much.
Yeah. So how to counseling to the patients to take treatment? That is the last discussion point.
I'm sorry, is that question for me?
No. I'm asking to Dilasa team,
Oh, yeah.
Mahatma Gandhi team. After that, I will come to you. So, Mahatma Gandhi team, please share your idea how to counsel this patient to take treatment.
To benefits the explain the benefits of the treatment.
Pardon? Hello?
Ma'am.
Yeah. Can you tell?
Explain the benefits of treatment.
Okay. Then what else? Anything else?
To decrease the symptoms and a nutritional improvement.
Okay.
So, again, understanding first of all, what are the treatments which are available? Whether the intent is to pursue curative treatments, are we doing any chemotherapy, radiation therapy, or are we planning to just pursue a comfort-oriented goal only? So I think that piece needs clarification first, and then ask the patient what the patient would want to do, which direction the patient wants to move in. And it doesn't have to be that the symptom control would not be going on simultaneously with the curative interventions also. Both of them could go side by side. But I'm not sure at this point in time whether, based on the information that we have, whether the patient totally understands, curative versus symptomatic only, and whether he's refusing those treatments just because, like you mentioned before, that, his symptoms are not controlled, he's in a very uncomfortable situation, away from his home environment, and he just wants to go home so that he could be, kept comfortable. So being kept comfortable, what does that mean? Does it mean that, I don't want to pursue any of the treatments, curative treatments that can be offered to me? Or going home means that, yes, I do not like the physical discomfort of the environment that I'm in. So that piece needs a little bit more clarification. And once you have that clarification, then having a conversation with the patient and the family, and like somebody mentioned, telling them about the risks versus benefits of, of the treatments that can be offered, and let the patient and the family make that choice. And from our side, like from the medical team side, then respecting those choices and putting a plan in place to make sure that those choices are respected, and patient symptoms are taken care of. So I think that's one piece that I wanted to add. So one thing that I've always kind of like taught my fellows and my residents is, instead of asking the patients what's the matter with you, asking the patients and families what matters to you is one of the most important clarifying piece of information that we could get, and then mobilize our resources according to that goal.
Okay. Thank you.
Mm-hmm.
Sandra?
So yeah, when you the question was how to counsel the patient. So like has already keeping in mind also the concept of total pain, that is physical, psychological, social, and spiritual aspects. So I would only be on the physical aspect, but as well as the psychological, social, and spiritual issues also. Maybe a patient may be depressed because of the disfigurement, or because of altered body image, as one of his leg has been amputated, or maybe it may be because of the effect on the family members, as it can be financially, or even embarrassment, maybe I don't know how they like, if there's any stigma or anything. And also it may be due to depression, the patient may be in depression, and there may be many factors to that. So depending on your assessment to the patient, then only you can plan your care and plan your counseling. I think so that is what we used to do. So first you assess the patient, and only after you know what the patient wants, what is he thinking, then only you can give your suggestion on, or you can help the patient with that.
Okay, thank you.
Thank you.
Okay, today's time is up, so we are going to finish these topics. So now today's excellent presentation from Sandra. Thank you, Sandra, once again. And
Thank you.
patient story from Sister Gaudami. Thank you, Sister Gaudami, for the presentation. And we have discussed the important points